Good morning, everybody, dear colleagues, dear friends. It's a great pleasure to welcome you on this second day of the 9th Esoc conference in Munich. My name is Thorsten Steiner. I'm a neurologist and neurointensivist. I'm a professor at Frankfurt and Heidelberg University. And it's a pleasure to welcome you together with Diana and with Terry, who will be our interviewer today. Hello.
So, good morning and
Good morning.
welcome. So Terry, tell us, what have been your personal highlights from the conference so far? Which findings really struck you the most?
Well, Diana, there's so much content from yesterday that was great, so it's difficult to pick a single highlight. What I was very impressed with was the large clinical trial session, because I think it shows how stroke research has evolved. So I remember many years ago we said we have to have trials with cognitive outcomes, and we saw a trial with cognitive outcomes that was positive. We said we have to have trials that involve older adults, and we saw the Precious trial that had a focus on older adults. And we said that we have to have trials of rehabilitation, and we saw some nice trials of rehabilitation. And for me, it was really that evidence of how stroke research evolves to meet the clinical needs.
Great, that's really an amazing clinical trial session, wasn't it? Fantastic findings, and the opportunity to discuss with people on site the findings is really amazing. So Thorsten, what about you? Do you share the same enthusiasm for Esoc and this first day?
Definitely. We all remember to the first conference, and as Terry just said, it's an amazing development that has taken place within the last 9 years until today. I was impressed to see again a very high number of participants, more than 4,100. I haven't counted the countries though, but I think it's a lot. And I think it's important because this is the way how the exchange works best. And I was very impressed by that.
Exactly, it was really a very great day. So moving to the topic of our discussion, the guidelines. So can you elaborate a bit on the overarching strategy currently for the guidelines at European Stroke Organization?
Yes, so we have guidelines that we want to be important for clinicians working in stroke. In the guideline board, what we often talk about is the 3 in the morning test. We want a guideline that you can use at 3 in the morning when you're dealing with a very complex stroke patient with information that is useful, easy to read, and will help your practice. So if there is one overarching theme to guidelines, it's making content that's useful to the stroke community in Europe.
Great. And what about the implementation in clinical practice and how useful this is for clinicians worldwide?
Well, I guess we would need feedback from the clinical community on how useful they are. We hope they're useful. One of the things that we're very keen on is being led by the clinical community. So the topics for our guidelines don't come from my head or from the head of the executive, they come from the clinical community in Europe. They tell us areas where they feel they need guidance, and then we take that and we form a question, and then that becomes the basis for a guideline.
So, Terry, can you tell us a little bit more about how are these guidelines? How is it done? How do people become involved? What is the technique behind it?
Sure. So we have a process. It's a process that we've been working on and improving on over many years, a process that you began when the guideline group first started. So very important to a guideline is framing the question and making sure the question is one that we can answer with evidence, but also that's useful to the clinical community. And we spend a lot of time trying to get the question right, because if the question is right, the guideline then follows. And we spend time defining the population of interest, the intervention of interest, and very importantly, what are the outcomes that are most important in clinical practice. We then work with our in-house methodologist to search the literature. That's becoming an increasingly challenging task as there's more and more biomedical literature there, but we're becoming more sophisticated in the way we approach that. We then find evidence relevant to the question, and a guideline team, often multidisciplinary, often from across Europe, will work with those papers to extract the relevant data and begin to formulate some answers to the questions, and then we have a framework for how we look at the quality of those answers, and we use the grade framework. So we have a process from end to end to allow us to deliver the highest quality guidelines possible.
Great. Sounds like there is a big group effort to complete a guideline. Torsten, you already contributed to guidelines, chaired guidelines, were involved in the beginning of the guideline board. So can you give us some insights into how this evolved over time?
Sure. So when this all started, actually it came from the Karolinska stroke update meeting. This is where people met and experts met, and then the result was actually an expert guideline, and then we had the idea of switching to the grade system, which took place, I think it was in 2014, and that was together with George and Tyus, and so we started working, and soon after the whole work began, we discovered that it is actually not only that we need to prepare guidelines, but we also need to make people aware of that there are guidelines. So there was the second task, which was how do we publish guidelines? And then we discovered, as you just said, that the thing is not easy. It's a complex thing to do. And so we need more than just a handful of people who is doing guidelines. And so the third task was born, and that was how do we educate people to prepare these guidelines. And this then led into another development, so that we applied for that the committee becomes a board with taking care of all these three different tasks. And next thing was we had to write down how to do it, which is then the standard operating procedure. Now we have the second standard operating procedure in place. Yeah, and this is how it all went.
Great to see how the process evolved over time and took us to where we are now, and we very much look forward into the future to see the future of the guideline. So Terry, everybody now probably is thinking, how can we get on action and contribute and be involved on stroke guidelines at the European Stroke Organization?
It's a really good question, Diana, and I would encourage anyone that's listening, that's excited about what we're talking about, to get involved. And you can become involved in the guidelines in lots of different ways. So I really would encourage people to submit topics for guidelines. That's how we stay fresh, that's how we stay relevant to clinicians in Europe. If you want to become more involved, you could apply to be one of the writing group for a guideline. We have a chair, that chair selects people, but they're often looking for extra people to come on board. And I wouldn't want people to think that they have to be very senior, that they have to be an expert in their field to be on the guideline. We have space for fellows, people who are earlier in their career, and the feedback we've had is that that's a really great opportunity for them. They network with experts across Europe, they learn about guideline methods, and they get their name on the paper that follows. We're also always looking for peer reviewers, so people that can have a look at our guideline product, give us critical feedback and help us improve the guideline. So at lots of different steps, there's opportunities for people to become involved in the guidelines.
I think that's great for everybody to know, and also, it's a great experience to participate in this process of creating clinical evidence-based recommendations. So, Torsten, what are you most looking for today at the European Stroke Organization Conference?
So, today we have, as every day, the morning session, and I'm a little bit biased because I certainly need to tell you that there is an ICH session, which is in room 5. And then we have the plenary session, which is really interesting. It's, if I should summarize it somehow, it has a lot to do with blood pressure management in ICH and in ischemic stroke. It is dealing with carotid stenosis and what we do about prevention after interventions, after different interventions. And then we have in the afternoon session, the next major thing, I think, which is the guideline session at 3 o'clock in room
13B.
13B. 13B. And then we have late afternoon sessions, and in between there are poster sessions, and I think in the evening there is the guided poster tour.
So Terry, any personal opinions on how the guideline session is today in the afternoon? So the guidelines that will be presented, and
So
the overall topic.
again, like Torsten, I'm very biased, but I'm quite proud of the guideline session that we're offering today. So it shows really the diversity of the topics that we cover in the clinical guideline group. I wouldn't want people thinking that we're just a guideline group that produces guidance on reperfusion, on acute therapy. We really cover the whole stroke journey, and that's evident in the session today. So we have guidelines on small vessel disease. We have guidelines on primary angiitis of the central nervous system. We have guidelines on motor rehabilitation, tenecteplase, and we have the new STRIVE guidance for neuroimaging and small vessel disease. So you can see there's something for everyone, I hope. And I look forward to seeing people in room 13B for the guideline session.
Yeah, I very much look forward also to attend that session. It will be a great overview of so many important topics in clinical practice for everyone, practicing stroke care across the world. So I think it's now time to sum up. So thank you very much, Torsten, for steering this conversation with me. Thank you, Terry, for your insights on this process. It has been enlightening to see how this is really a group effort. And so thank you also to the Guideline Board and the Guideline working groups for their great work, and it's very useful for all of us to implement our best clinical practice, evidence-based clinical practice. So thank you all. Don't miss the highlights at 4:30 and the interviews. Very much looking forward for the interviews as well, the PI interviews at 6:30. So thank you very much, and see you.
Good morning from Munich, from Esoc 2023. My name is Jens Fieler. I'm from Hamburg University Hospital, Department of Neuroradiology, and I'm the host of this discussion that we are going to have. And it's a great pleasure to welcome Professor Mühlenbruch from Heidelberg University Hospital. And there's reason to celebrate here because we have the 10th anniversary of the Sofia usage in acute stroke treatment. And I remember still in 2013, we lived in a completely different world with all those negative trials. And then Sofia emerged. So what was your first experience?
Thank you, Jens, for the kind introduction. So in 2013, at that time, we usually used the stent retriever as our first line approach for mechanical thrombectomy. But still at that time, we used an intermediate catheter. And the Sofia was introduced in 2013, as you mentioned before. And we immediately realized that the Sofia catheter is a catheter which is very easy in use. So therefore, first we started to combine the Sofia catheter with our stent retriever approach. And we collected data from different hospitals together, and we combined this data with our data. And 1 year later, we published the first multi-center case experience with the Sofia catheter in combination with the stent retriever. And we realized that this catheter is easy in use and can be combined with the stent retriever in order to get very successful recanalization rates. And this is what you see here on this slide, that at that time we were able to get TK2B or 3, the so-called successful recanalization, in more than 87% of the cases.
Yeah, and this was, I still remember when you presented the results for the first time, I think it was at Link.
Yeah.
And I was really impressed. What has changed since then, if you look for the coming 10 years? So this was the starting point?
That was the starting point, correct. But in that time, right, when we start with the use of Sofia, we realized that the Sofia can also be used as a standalone system for first-line aspiration. So immediately, and this was idea from Thomas Liebig as well, so we combined our data from Heidelberg and at that time from Munich. And we realized that the Sofia can be used as an aspiration catheter. And the first one was the Sofia 5 French, as you can see here. And we obtained a TK3 result in 60% of the cases, which was really good. So, and that was the starting point when we decided to use the Sofia catheter as a standalone system for aspiration.
But it was originally not designed as an aspiration catheter.
Correct. It was an intermediate catheter, and at that time it was only available as a 5 French system. But then the company realized the potential of of this catheter platform, and in a very short period of time, they introduced the Sofia 6 French into the market. And again, we did the same what we did before. We collected data from a couple of centers. It's still retrospective, but 85 patients. And you see here that combined TK2C and 3, so now it's more focused on a higher recanalization rate, was still very good, so more than 60%. And in only 1/3 of the cases, a stent retriever was used.
Yeah, and if you look at the Sofia as a tool, so you used it personally, and how do you feel about the Sofia as a catheter for training younger interventionists? So are there issues?
So that's a good question, because it's all about the training. And if we talk about training, then we have to talk about the ease of use of the device. If the ease of use is good, or let's say if it's easy to use, then you will receive a high rate of acceptance in your team. And it's all about the placement of the catheter. If you have a bulky catheter which is difficult to place, then nobody likes to use it. But if you have a catheter which is easy in the placement, let's say at the level of M1, so then you will have a high rate of acceptance, and that's I would say very, very. That's the case with the Sofia catheter. Not in our center, and all the other centers as well.
And how do you use it with this famous snaking without anything inside, or?
Basically, what we use the regular guide wire, but we keep the regular guide wire inside the Sofia 5 or 6 French catheter, just 3-4 centimeters below. It gives more stiffness to the system, but the tip is still very soft.
An 038. Or?
Yes, correct. Okay. 035 in our case. And then you can snake it up to the carotid T or M1.
And this is also safe and effective in the hands of less trained people.
Yes, yes.
Yeah. And this, you mentioned in the beginning, and this is this slide, that originally you used it together with a stent retriever. Yeah, I assume there is some message you want to convey here.
Yeah, of course, there are now 2 randomized controlled trials, the ASTA and the COMPASS. The ASTA failed, as you all know, but if we look to the recognition scores at the end of all procedures, then you see that there are no difference between the aspiration cohort and the stent retriever group, and this is the same for the COMPASS trial too, but here the primary endpoint was different. Here it was the outcome of the patient. That's not important now for this discussion. What I'd like to show is that basically if aspiration works, then it could be the case that this is a very fast procedure, and this was possible to show in this COMPASS trial. And it's the same with the Sofia catheter. I know that in this trial other catheters were used, but more or less it's the same with the Sofia catheter family. And you see here also other data from US, for example. Here they looked at more than 300 patients, and they observed more or less the same results what we published before. So here a TK2C3 result in 50% after aspiration, and the stent retriever use was very similar in 29% of the cases.
And your handling of the Sofia and the overall procedure, has it changed over the last 10 years?
Basically, nowadays what we do is if it's more location dependent. So if we have, let's say, occlusion which is more distally located, like in the M2, we go more for a stent retriever approach. But if it's an M1 occlusion, then we go more for the aspiration approach, because there are many publications saying that the M1 is actually the best indication for performing first-line aspiration. And this is what we figure out with the Sofia approach as well.
And why? Because it's simpler, because it's cheaper, or?
Basically, it's dependent, I think, about the fact that you can easy reach the M1 with a catheter, and you don't have, not in all cases, but in the majority of cases, you don't have a tight angulation. So you need a good engagement of the catheter tip to the clot, and then you are successful. If you're not able to get in good engagement because of a tight angulation, for example, then you are not successful with your aspiration. This could be also the case, for example, if we talk about carotid T occlusions.
Okay, so for anterior circulation, you more or less always use the Sofia.
We use it always as an intermediate catheter, and for M1 we use it as a first-line aspiration approach. For M2, for example, we use it together with an stent retriever. Yeah.
And more distal occlusions, do you try to place maybe a Sofia 5 as distal as it gets?
Yeah, So that's possible, especially if we talk about occlusions located in the inferior trunk, because there usually you don't have a tight angulation. It's more the case if the occlusion is located in the superior trunk, and usually the inferior trunk is larger in diameter. So you can try if it's a proximal M2, but if it's a distal M2, then definitely we go more for the stent retriever approach.
Yeah, so we were starting to use the Sofia 5 with balloon guide catheters as well. We will have a conversation later on in this discussion on the Bobby, but what's your feeling about balloon guide catheters and Sofia?
Yes.
Without Bobby, with whatever we had in the past.
So basically we try always to combine in the anterior circulation the use of Sofia with a balloon guide catheter.
So aspiration plus balloon guide.
Yes.
Okay.
Yeah.
Okay. Interesting.
So here you see meta-analysis about the Sofia catheter because of the lack of prospective studies at the moment about the use of Sofia. Then usually what you can find on the literature are meta-analysis, and here you see the direct comparison between ADAPT techniques, so the aspiration first-line approach, versus the use of the combination of stent retriever and Sofia. And basically what the data shows is that there is more or less an equivalence. So there is no difference in the first pass rate and the final Tiki score, or that's also very important in the complication rate.
Yeah, I think you mentioned it already, and there is no escape now for me to ask. There are no good prospective studies, but there is one.
There is one. Unfortunately, I'm not able to show you the data right now because we finished the data analysis just a couple of weeks before the meeting. So this is the Sesame trial. This is a trial which we conducted in Europe in more than 10 centers. We collected data from almost 250 patients about the use of Sofia 6 and 5 French for a first-line aspiration approach. And so far what I can tell you, the data confirms what we have seen from the retrospective multi-center experience.
Finally we did the imaging collab for this Sesame study, so congratulations, because it's a completely different ball game to run a prospective study in many centers in Europe, and it's completely different data quality. So looking forward to hear about these data. Anything else you want to mention about the Sofia? Maybe do you want something for future developments, nicer color or something?
Nicer color would be nice in order to differentiate. No, but I think there's definitely room for 4 French system. I think for us it's more important than an 8 French system. 8 French I think is nice to have, but it's not a must. So for me, definitely 4 French is much more interesting, because nowadays at least 20 or even more than 25% of the cases are occlusions distal to the M1.
Absolutely, and I hope we will get it. I'm pretty optimistic, because this is obviously an interesting new application, and let's see what the studies are going to show.
Yes, thank you.
Okay, thank you, Marcus. It was always a pleasure, and glad to have you as one of the pioneers of Sofia here and have your insight. Thanks a lot.
Thank you, Jens. Bye-bye.
Yes. So we are back here from Esoc in Munich, and now it's my pleasure to introduce Dr. Power from Beaumont Hospital in Dublin, Ireland. Sarah, the discussion is now more about standardization. I think you did a great work at your hospital and going into this subject. And for me personally, I'm very much in line with the idea of standardization. But in my experience, it's really hard to achieve. For us as a discipline of neurointerventionists, everybody is the biggest and knows best. And can you maybe do you have a wonderful team that just is inclined to this kind of stuff?
Yes, well, thank you very much, and it's a pleasure to be here. We do, of course, have a wonderful team, and everything is a team approach. But yes, in 2017, we decided to move to a standardized approach, first aspiration technique for thrombectomy, and that decision was made because we had seen the success of using aspiration on an ad hoc basis. Previously, we'd been mainly a stem retriever centre, but once we had some experience of using aspiration, we felt that this really seemed to be a beneficial technique, and so we moved to a standardized approach. So for our standardized approach, we have a standardized way of putting up a guide catheter, which is very, very fast. The whole procedure is very, very fast. We put it up in one maneuver, no exchange, over a diagnostic catheter. And then once we get access, we are simply snaking for the most of the time Sofia, our preferred aspiration catheter, up through the ICA and to the face of the thrombus with very successful results. And for those people who I guess haven't seen the snaking technique or the aspiration with aspiration, this is the Sofia being advanced through the blood vessels, and we either put it on a contrast flush or, like previously mentioned, sometimes we leave the 035 wire proximally in it because that's a device that we already have out and we've already used to place our guide catheter. And we have advantages with this technique. I suppose you get very familiar with it, you become very good at it, you can become faster, and all of our nursing staff know the collection of equipment that we want to have out, and it's very easy to anticipate our next steps.
Yeah. So the typical discussion is, you can't do that because each patient is different. You have sometimes a stenosis, sometimes a very tortuous anatomy. What's your experience about this? So it can be overcome?
Yes, it can be overcome. So an example would be tandem occlusions, for example, where you can argue, well, this can be very difficult, with tandem occlusions, but yet we do still use this technique with tandem occlusions. Of course, we first need to pass the occlusion, and we are, in the main, we address like the distal occlusion first and then come back and address the stenosis. So once we have a guide catheter placed in the ICA beyond the stenosis, the technique is exactly the same. And actually we're using it now just not for distal M1, as you can see here in this case, or M1 at carotid terminus. We're going out more distally with even the 6 French Sofia out into the M2.
And as you mentioned guiding catheter, so how do you do it in a similar way like what Marcus just discussed? So guiding catheter a few centimeters back, this is the way you do it as well?
Oh, for the guide wire inside? Yes, yeah. We don't put it at the end of the Sofia, we keep it back, and even you can see probably where my typical placement of it would be in this video. So yes, we keep it back, but it's more just to have some proximal support. But often we don't even need that, and I would often just put a contrast flush on it and just put it up that way. Yeah.
And how frequently do you have to change the procedure? So let's say you mentioned tandem occlusions.
Yes,
how frequently is it you can't pass?
That we can't pass with a guide
Yes.
catheter.
Or with the Sofia. I mean.
Yeah, what I might do is I have so these were the results actually of our the study where we compared standardized aspiration first approach for thrombectomy versus a previous stent retriever group, And I might just briefly mention these. And
Yes.
then we also looked at another study at how easy we were able to pass anatomical hurdles with the Sofia. But for the results of our study, in contrast to the Astra and the Compass trials, we actually demonstrated significantly higher recanalization rates with aspiration first over stent retriever. And we were very fast. We were faster from growing to reperfusion time than both of those trials. And I think that was down to our standardized technique.
Yes.
And also we showed a significantly faster time from procedure length, first angio to first reperfusion, growing to reperfusion. And Astra didn't do that, Compass did. Now, we also showed that we needed a fewer number of passes in order to achieve TK2B3 recanalization. We did require rescue therapy with stent retriever in some cases, 18%, but the reason for that...
10%.
18%.
Okay.
And the reason for that was kind of twofold. About half of those were where we weren't able to get the clot out with aspiration, and the other half would be where we might have, like now, a distal M2 occlusion, and we would go and take that out. But to answer the question, we were always asked, how frequently are we able to get the Sofia to the thrombus? And particularly when we got the wedge microcatheter, we realised that actually we were able to get to the thrombus either alone with the Sofia or with the wedge microcatheter pretty much virtually all of the time. So Sofia alone, passing that to the thrombus, we can get that, we can reach the face of the thrombus in 75% of cases. 25% of cases, our go-to now is that we put in the wedge microcatheter. And when I put in the wedge microcatheter, there was only one case out, so 37 of 38 cases we were able to reach the occlusion. There was just one case where we weren't able to reach the occlusion, and we had to use a stent retriever first. So the addition of the wedge to kind of our procedure has been a really major gain for us and has allowed us to get to the clot.
And you are using it,
100%
you have
of the
it
time.
in all the time
Yes,
available, you're still using it?
Exactly, yeah. So we wouldn't open it until we need it, but it's there, and they're sitting with the wire. The nurses know they have it ready to go. And if we can't pass the anatomical hurdle, most commonly it's the ophthalmic, sometimes it's proximal tortuosity. But if we can't pass that anatomical hurdle, then we just open the wedge.
Yeah, I think that's a very important fact. And you mentioned the studies, and Compass was intentionally very balanced between the aspiration users and the stent retriever users. And this was not the case in the Astra study. And if all the participants in the Astra study would have been like your center, it might have looked different. So this brings me to the point of training. So I think one of the beauties of standardization is training. Is it complicated to train?
To train.
Yes.
Yeah. It's not complicated with this technique to train, because you can. It's actually quite an easy technique to do when it works, and then with the addition of the wedge microcatheter, also makes it easy. You know that if you can't get past the anatomical hurdle the first time, then you tell your fellow, that the next step is to use the wedge microcatheter. There's a little bit of instruction for them to how to use the wedge microcatheter, which uses ledge effect and exactly positioning of the two markers that show the dilated portion of the catheter, and to position those across the anatomical hurdle, like so for example across the origin of the ophthalmic. But overall, actually, I think an aspiration first technique is easier to teach than using stent retriever. Now, of course, you need to be able to do both to be a neurointerventionist who works in stroke, but it is a relatively easy technique to teach.
What's your aspiration technique? Do you use a syringe or a pump?
Yeah, so we use a syringe, So we use a 50 ml Luerlock syringe, which we turn on. We wait for a short period of time, somewhere between 30 seconds to a minute, and then we start to withdraw the Sofia with fluoroscopy.
Okay. Have you had any experiences with cyclical aspiration, some more fancy stuff?
Not personally, but I have seen it. I have seen it in demonstration. It looks very, very interesting, and I think if we I mean, I think it's really, really important that we modify our technique. You know, what we're trying to do really, if something shows a benefit. So if cyclical aspiration was going to show a benefit is demonstrated, then it would be certainly something I'd consider, you know, moving to.
Yeah, because it wouldn't change the mechanical approach and everything.
Exactly.
It's just a maybe add-on benefit.
Yeah.
And obviously the complexity is reduced and the cost.
Yeah.
Did you analyze the cost?
We did, absolutely, yeah. So it's a much more straightforward technique. And we realised that we looked like we were using less equipment. So we formally looked at this. So by doing so, we had 3 groups. So the first was a stent retriever first group, 127 consecutive cases. This was from the comparison study. We compared the first 127 cases after we introduced the new standardized aspiration technique. And then we also included a more recent group because we wanted to be sure that any gains that we had, they were maintained over time. And we record all of the equipment we use for every case. And then we calculated the cost for the equipment used based on the local price in our institution at the time. So we chose a time date as December 2019. And then we compared the equipment costs across the group. And we kind of excluded things that were definitely common to both procedures using stent retriever versus aspiration, like, for example, a sheath, a guide catheter, an 035 wire. But what we showed was that there was a significant cost reduction in using aspiration first technique, and it corresponds to, when we looked at it, between the groups, a 40% cost reduction overall with aspiration first compared to stent retriever. So that's really significant for a centre like ours. It works in the public system.
Yeah, because it takes into consideration all the bailout procedures as well.
Exactly, yes. So if a stent retriever was used in the case, it is included in that costing, and the figures you see there is the mean equipment cost per case, and
the wedge as well.
Yes, no, at the it does. It includes the wedge as well. Yeah.
Okay, so one of the rare observations when something became cheaper than before.
Yes, exactly.
That's good to know. And I need to go back to the beginning of our discussion with the team. Can you share some insights on how you got there to this standardization? Because this is, for me personally, we are really struggling to agree upon a standardized approach. How did you do that? Is it just luck, or are you smarter than we are?
Well, some of it was certainly a conversation. I think we'd all, so there were actually 4 of us, and you see in the paper, it was 3 of us in the end that switched to the standardized approach at that particular time. And so it was the work of 3 of us that you were looking at. And the 4th did continue for some time to do mainly stent retriever procedures, but is subsequently now kind of coming more towards the standardized approach. And really it was a conversation, and what we are constantly striving to do is to try to kind of make our procedures faster, to improve our recanalization rates. We have a constant quality improvement program, and we felt that this could potentially, you know, be a benefit to our patients, of course, initially.
Definitely.
And so that's why we decided that we would, as a group, move to that standardized approach.
Yeah, congratulations. And I think we need to find ways to communicate this more, because it helps everything, training, but also studies, if we have more standardized approaches. So congratulations to what you did, and thank you very much for coming.
Yeah, thank you very much.
Thanks, Sarah.
Thank you.
Yes, welcome back to the Esoc conversation on several topics surrounding microvention. And now our final guest is the local guest, Dr. Berg-Behrens from the Technical University of Munich. Tobias, the subject is the straight study with the Bobby. So can you start explaining what the Bobby is?
Of course. First of all, thank you very much for the introduction. And yes, this is my home base here in Munich, and I'm very happy to be here. So this straight study is to evaluate the Bobby, and the Bobby is, in my opinion, a new generation balloon guider. So we had several generations before, and now I think we could say it is the third one.
Okay. And yeah, what can we expect? So I personally haven't used it, unfortunately, but yeah, what can we expect? What's the difference of the third generation against, let's say, the old cellos and so on?
I think we all know that there are a lot of reservations in the neurointerventional community using a balloon guider. And the reasons for that were based on the difficulties that we all had by using the older generations. So they were quite stiff, and the second one was a little bit too floppy. And I think that was one of the main reasons that it really did not reach that the majority of neurointerventionists really used these kind of guiding catheters, although the data that which shows that the approach works, they are quite good.
Absolutely. There are, whenever there is any comparison between balloon guide use, yes and no, there is a difference. We even found in our own small study on high resolution DWI, very, very few hits if balloon guides were used, and it was a study of 30 patients or something. It was highly significant. So there's something to balloon guide catheters, but we most of us still don't like it, as you said, and because we are under time pressure.
Exactly.
Do we have to use this thing? So, and this comes to preparation.
Yeah, that's one thing. You have to change your established practice. So you have to add another step, and one of them is the preparation, which is a little bit different by using the Bobby. It's more like these double balloons, like the scepter.
Yeah.
So where you have an antigrad flush of contrast media, I think you really get used to it quite fast.
Do you do it yourself, or your assistant, or the nurse, or?
I do it myself. Yes.
Because,
at the beginning,
because of what? Because it's difficult.
No, it's not difficult. You just have to have a little bit of routine in it, because if you are too fast, then you can blow up the balloon, or if it's too slow, you do not really see if it works. But actually, you only have to do it maybe 2 or 3 times, then you're safe with it.
Yeah, got it. Yeah, and I think, again, all the data we have show superiority of balloon guide catheters. And now you come with this study, which is great because we need prospective data. And what's the purpose of this study? It's just for approving something, or do you want to collect other data as well?
Well, I think it addresses different aspects. So these are the primary endpoint is a technical one. So the first aspect is that we want to show that using a balloon guider as a standard approach is working in nearly all of the cases. And then we tried to be as close to the historical cohorts as possible regarding the inclusion. Regarding the inclusion criteria, so that we have at least an idea how good are we by using these kind of approach. Of course, it's a single arm study, so we are limited.
I think
regarding
one
this.
critical question would be, when do you enroll the patient? Whenever the bobby is up or before?
Well, no, we
Because then you have a 100% success rate. If
Yeah,
this is
you're
your
right.
inclusion
Yeah.
criteria.
So no, it's not. If
Okay.
you use the bobby, because we had also limited access to the bobby at the beginning, we really tried to only use the bobby if we at least try to include it in the study. Sometimes there were some exclusion criteria like age or something like that that excluded.
Can we have a look at
Yes.
the inclusion
Yes,
exclusion
of course.
criteria?
So
Yeah,
these
okay.
are more or less the classical inclusion
Yes.
criteria. It's
And-
similar to the
And the other technique, does it? You can use any thrombectomy device or aspiration only possible.
yes. You are not restricted to any technical approach. So we usually use as first line a combined approach with a Sofia and a stent retriever, but actually we switched a little bit, so we more and more use or try also direct aspiration,
Okay.
because one of the largest advantages of the bobby is that it's compatible with the large Sofia.
Yeah, but this is what we were asking for many years, to have something 6F Sofia compatible, and finally it's there. So
Yes, and this really changes a lot, I think, and also it will lead more to the approach that you might try the first step, the aspiration.
I get it. And who is participating in the study?
Yeah, we have actually 9 sites. No, that's here. These are the enrolling sites, 6 of them in Germany, 3 of them in Switzerland, and our enrollments until today this is not true anymore, so we have 125 until now. Planned are 270.
Okay, cool.
But maybe the data, we'll have an interim analysis quite soon, and if the data are clear enough, maybe we will stop, and this is not decided yet.
Yeah, so we mentioned briefly in the slide before, we go back and forth a little, sorry about that. The primary endpoint is TICI-2B rate. Is this the best endpoint to show the benefit of the bobby, or?
Yeah, we had to decide if we use a clinical endpoint or a technical endpoint, and I think actually it is a technical aspect of a complex procedure.
Yes.
So you always have different aspects going inside these endpoints, so you have to decide for one side or the other. And we decided to take this one because I think it's the best. At least the technical aspects are better represented if you use a technical endpoint, and the clinical ones follow later on.
And do you also gather data on distal emboli and?
Of course, we have a lot of secondary endpoints, and there are embolizations to new territories, infarctions to new territories, and also one very important one, which also is for better showing how the mechanical properties of the device is the placement, because we know that the better you can achieve a placement quite distally, the better or the higher will be the success rate. And this is also what we saw.
Yeah, you saw already something?
Yes, we have.
I need to learn more.
Yeah. Yes, we have the preliminary data of our first 81 included patients that have been core lab controlled. So you have to keep in mind this is preliminary data, but we saw a quite high rate of successful recanalization. With a 96%, which is quite good.
And this is at end of the procedure, right? It's
Yes.
not first
No,
pass.
it's not
Yeah.
first pass.
Okay.
It's end of the procedure.
Mm.
The first pass I do not have actually
Mm.
yet.
Yeah.
There are several other endpoints,
Yeah.
the rate of ENT and all of these.
Yeah, of
smaller
course,
ones.
it's not finished. I understand. And
So
I
this
see.
is actually the main endpoint,
Mm.
and the other one I mentioned before is where could we place this kind of catheter?
Mm.
Is this analysis, so we could achieve a quite good placement of the bobby in the ICA and relevant proportion
Mm.
also in the distal parts of the.
And is there a point in the protocol where you say you have to go as distally as possible, or is this just where the operator thinks that this is the optimal
No,
place?
we leave it to the
Yeah.
up to the interventionalist. Of course, the goal is to place it
Mm.
at the skull base.
Mm.
This is defined in the instructions, but of course you always have to adjust to the anatomical situations
Yeah.
and you see actually this is one of the examples that I can show you. Here you see these are the difficulties that we have to deal with if we use a guiding catheter, and in the first and second generations it was nearly not possible to do these kind of
Because of just the kinking.
Yes.
Yeah. So
And-
of the catheter as such.
Yes.
If you are not
Yeah.
able to straighten the vessel, yeah.
Yes, and I think with the third generation devices, this becomes more and more possible, and so
Mm.
you do not have to think about a direct puncture anymore.
Yeah.
And you have the additional.
And is this a patient from the study?
This is a patient from the study.
Okay.
Yes. And
Cool.
then we also have a. Here, this is this patient actually, where you already see how it's straightened up,
Mm.
and then where we try it now. I think the video
Mm.
runs. So we see where you see that we can place it nearly at the skull base. So
Yeah.
this was the goal.
Yeah. Yeah. And dissections, and so this is so obviously the study is running.
Yes.
No concerns from a safety side if you go distally with the bobby and so on.
No, we did not have any device-related events up to now, but of course there are several. There will always be some issues. For example, you have the balloon will not inflate or deflate, but these are rare events, and there were no events that led to a harm to the patient. So I think the overall benefit is quite clear.
Yeah, that's very good. It's really good. So the recruitment seems to go very well. So really happy to see that.
Yes, it goes well. It could be faster, but that was the
Always.
initial decision that we want to stick to the other inclusion criteria.
Yeah. I think makes a lot of sense. Yeah, I hope we will see the data very soon. And
I hope so too.
I'm really looking forward to the result of all of it. There are so many things we could discuss about the relation of the positioning versus collateral floor, and how does it actually achieve this occlusion effect and help aspiration. And so I think there are a few papers that looked at this already, and I think this would be wonderful data to have all these secondary analysis. And I think that's even more interesting than just to see, okay, it's working. That's what we expect. It needs to be shown. But yeah, cool. Thank you. Tobias, was a pleasure. And yeah,
For me too.
having you here in Munich. Thank you very much.
Thank you too.
Thank you.
Good morning. I'm Kathy Schmoyer from Neurologica, and I'm here to speak with Dr. Klaus Fassbender on the benefits and challenges of setting up a mobile stroke program. Dr. Fassbender, thank you for meeting with me today, and on behalf of Samsung Neurologica, we're honored to be here and speaking with you. Our first question, Dr. Fassbender, is that you were the inventor and founder of the mobile stroke concept, with the first one being introduced in 2008. What have the benefits been of this revolutionary concept?
Good morning.
Good morning.
Thank you for these questions. We started this concept with a publication in Stroke 2003, and then we were first on the road in real life emergency care in 2008. And the idea was to bring the hospital to the patient. We were quite frustrated to see that many patients came too late to the hospital and they could not get thrombolytic treatment. And that's why we had the idea to bring the CT scanner to the patient in order to save much time and to improve efficiency at intersections. So the first advantage is obviously earlier thrombolysis. And the second advantage is that once you know what the patient has and what kind of vessel disease he has, hemorrhage or ischemic stroke or large vessel occlusion or no large vessel occlusion, you can make really good decisions where to transport the patient, either to a comprehensive stroke center or to a primary stroke center nearby.
Thank you. What kinds of challenges have you faced with setting up a mobile stroke program?
Well, first you have to have a very friendly collaboration with the emergency medical services. And of course you have to convince them. And then you have to get into contact with responsible politicians who have to take care that everything works. And finally, you have to convince your colleagues and neurologists. And many of them still think that stroke management, and it is now, is already perfect and fast enough because we have enough stroke units and there might be no need for mobile stroke units, which is obviously not the case.
Mm-hmm. Are there challenges triaging the patients to different hospitals in your practice?
Well, we perform in most cases a CT angiography, and based on this information, this vascular pathology, we triage the patient, and that's in my eyes the correct way. And we do not bring the patient to the first hospital, which is unable to do intraarterial treatment, and then make a secondary transfer, which usually lasts for 1 or 2 hours even. And there are studies showing that. So we get it right on the first time, and this is quite good for the patient's outcome, I would say.
Mm-hmm. What do you think are the best practices of your program that other people who have programs can learn from?
Apart from the setting of our ambulances, we constructed the first ones in the world, and we have also practices such as team approach and parallel workflow, and which maybe others could learn from, maybe. And of course, in the last time, we increased the spectrum of our mobile stroke unit to include other emergency to cover other emergencies. So we call it hybrid MSU, which is a multi-purpose MSU, which is our latest project.
I've been reading about that. It's very interesting. Are you performing CTA and or brain perfusion in the field, or are you waiting until the patient arrives at the hospital?
Well, the idea is not waiting for anything,
Yeah.
and directly getting the important information for triage decision making, and that's why we do CTA.
Mm-hmm. And do you use any type of AI technologies?
We were the first to show that at least electronic aspect scoring as a program from one company works nicely in a mobile stroke unit to give us indications about early ischemic changes in the brain.
PCD technology is new, talked about in many places now. Are you familiar with that, and do you think it will be benefit to a stroke program?
Yes, it's a very interesting new field, and obviously things are always going forward and new opportunities for research will come up, and this is a technology which quantifies the energy of photons rather than of X-rays, and which makes, in your case, in your scanners, the information much more precise. And of course, there's less radiation, which is, and especially for mobile stock units, a big advantage.
Yeah.
And if this is done as you did, still in a scanner which has the same size as, for example, the Omnitom, it's a good starting point.
It's true. What are the barriers to the adoption of this technology, mobile stroke? What are the barriers to it that you're finding here in Europe and in other parts of the world?
We already have quite good clinical outcome data due to the work of the Berlin group and at Houston. But we might still need a little bit more evidence. Maybe one could set up a registry of all patients' data to convince politicians and colleagues about the advantages. In the end, it's all about money and reimbursement. I think it takes a couple of times. We have to consider that mobile stock units are still a very young field. It's still a very young field, and it might take a while. But sooner or later, I see many mobile stock units around in order to treat the patients better than now.
Yeah. Well, thank you for your time today. And I really appreciate talking with you, and I hope everyone else appreciates talking with you. And again, thank you.
Thank you for the questions.
Yes.
Thank you.
Welcome everyone, good afternoon. The second day, we've all just come back from the second plenary sessions where we've heard some very interesting results again from nice performed randomized controlled trials. My name is Robin Lemmens. I'm joined here by Silke Wolter.
Hello everybody, we are here with 3 experts on ICH, Charlotte Cordonnier from the University of Lille, Thorsten Steiner from the University of Frankfurt and Rustam Al-Shai Salman from the University of Edinburgh. And we would like to discuss this very exciting session we've just visited. Shall we start with the UK PDS trial? So that was an interesting trial assessing the effect of randomization to tight or less tight blood pressure control and intensive blood glucose control. They treated their patients for 10 years and collected data on incidence of stroke and dementia after 44 years. What are your thoughts on this?
Well, I think it's an incredible amount of work and quite an original approach, because making the best of data collected in the 80s in 2020. However, I'm not sure we can make anything in clinical practice from what we heard. I think the approach is interesting, but I mean, what would be your take-home message about that?
We also all like to have short messages. I think the trial was at least not positive. I'm not sure about whether we can use the results, because we have such a long observation time and many things happen in between. So I don't know what we can take from that.
And what do you think about this treatment period of only 10 years? Because people are getting older, participants are getting older, and more likely their risk factors increase, so they need more tighter control later on in their lives. And as far as I've understood, they've stopped the treatment then. So
yeah, it could also be counterproductive if you do not look at it carefully, because of course when we deal with a patient with a risk of stroke, we insist on the daily management of risk factors, and what you did 30 years before may have an impact maybe on the burden of chronic lesion and on the way you'll be able to improve after a stroke, but I don't think it has such an impact on preventing one single event.
So how would you even, thinking about that, and first I'm thinking about getting funding for trials, how would you nowadays design such a trial? Do you think this would be feasible to have it properly designed and funded, or what are your thoughts?
Yeah, I mean, I think in defence of this trial and the extended follow-up, this is an extremely cost-effective, cheap way of looking at long-term follow-up.
That's true.
And I think if you look at the left-hand end of the survival curves, where you see separation between the curves, it's showing you the benefit that UK PDS did find in some of the comparisons early on. But what's difficult as fewer and fewer patients remain under follow-up is that the right-hand end of a Kaplan-Meier curve is quite unreliable. The important thing, though, Robin, is that we know that routinely collected data can be accurate for some of our major stroke outcomes. And I think it's really novel that this trial looked at dementia as an outcome, ascertained both by investigator reports and routinely collected data. So it seems to me that the results are quite valid. It's just that we need to look for interventions that might have a very durable treatment effect, trialed in enormous numbers of people. And let's remember that these trials were that the trial included only a few hundred. So let's look at all the other trials that have massive numbers of people and are following them up for events that can be reliably collected by routine data. And with maybe €100,000 more, we can look perhaps with greater precision at durability of treatment effects. So I love this approach.
Yeah, because that's probably the way we should go if we really want to collect data for such a long time interval. It's not possible to get that funded by having research coordinators collect all that information. So routinely collected data should be used for such kind of treatment.
Yeah, I mean, compared to 44 years of site visits.
and also it's probably where Europe and the European Stroke Organization makes sense, because you probably cannot address this issue just one country by itself. It's really
that's
we
very
all
true.
have an administrative linkage that are
Yeah.
now available. We just don't really know how to do it in our
Yeah.
own country and then try to merge
To mer-
this approach at a European level.
So, Rossum, just one question to you. What do you think about that the population might have changed in between? For example, we heard during the talk, that the body mass index has changed over time, saying that people are more heavyweight now than they were 44 years ago. How do we deal with that?
Yeah, I mean, obviously the background characteristics of the population and characteristics of our everyday care do change over time. It's always the problem we have with trials, isn't it? Shall we repeat a trial that was done 10 years ago again now to check it's valid? But I think it's probably about whether the treatment effect is generalizable to our current population. Is the difference that's observed valid? Because I think the characteristics of the patients may change their background level of risk, but I don't know how much that's actually going to affect the relative treatment effect. It might affect the absolute benefit, but maybe not necessarily the relative.
Yeah, that's a good point. Yes.
So, but we heard many more data today. So we want to talk a little bit about the ICH trials as well. So one was focused on surgery, looking at not so many patients. Well, for a surgery trial, probably a lot of patients. But then the other trial looked at thousands of patients with an intervention. So what are your initial thoughts about the results of these studies? And maybe we can start with the surgical intervention. Thorsten.
Well, first of all, it's very interesting and nice to have the first and today actually 2 positive trials on ICH. There is no doubt about that. It was a lot of data we have seen. Referring, for example, to the inclusion criteria, it seems to be, or it would need that we put this in relation to other trials and results from other trials we know. And because they had different inclusion criteria, for example, we have patients in there who had a high amount of interventricular hemorrhage. We have patients in there who were included with a Glasgow Coma score from
5 to 14.
5 to 14,
Yeah.
which is quite a
broad range.
broad range compared to what we regard when we do recommendations and we speak about how patients do develop over time and how we react on deterioration.
Yeah. I think the way I see surgery, probably not with this trial, but I don't only see surgery just as a life-saving measure or just on people who deteriorate. I probably see surgery in the way that you have to prevent secondary injury due to the blood that is in the brain and that shouldn't be there. So we'll probably go towards less invasive strategies just dedicated to take off the blood, whatever the clinical state is, in the next few years. I mean, that's my...
What was also quite interesting that the group with deep ICH, basal ganglia ICH, that was then terminated because they actually didn't do very well with the surgery. So what do you think, what could be the reason for that? Is it just a trauma caused by the surgery itself, or what do we do with these patients? I suppose that no one of you would now drag a patient into the theatre only based on these results.
Yeah, probably they call it mini-invasive, but it's still surgery.
Yeah.
So you still have to go into the brain, and they probably have to develop less invasive strategies that will be just dedicated to the deep ones.
Yeah, I think we need to look at the device. And the device is not just a small tube you insert
it's
in
quite
there.
it's quite a big one.
You first start with inserting something which has a diameter of 1 centimeter, something like that, if I'm not mistaken, and then you start with suction,
and these shear forces can of course cause damage in the surrounding area.
So we heard many more, I mean, over the years we've heard more trials, results being presented about surgical interventions. If you now compare these results to what we already know. So what are your initial thoughts? Of course, not knowing all of the data because it's just been presented as a short presentation. You don't have all the insights, but what's your idea about that?
Well, I mean, I think we've been feeling optimistic about minimally invasive surgery for a few years. And there was a very nice systematic review and meta-analysis in Annals of Neurology done by Lottie Sondag and others in the Netherlands, dividing the trials that have been done of surgery into those that used craniotomy as a technique and those that used minimally invasive surgery. And that already showed us that there's promise, a bit of heterogeneity, but there's promise amongst the minimally invasive surgery trials. So I think this trial now arrives on that background. I think, so for me, I'm not quite as surprised and elated as some people about the result, because I was already feeling optimistic about minimally invasive surgery. The question for me is whether this very small trial with an arm with a subgroup that was dropped, as Silke says, early, needs to be replicated for us to be sure, because let's remember it's still a small trial. So very optimistic. I feel great, but I would like it to be replicated. And I'm really wondering whether my surgical colleagues are going to randomise now, or use this, or continue their nihilistic approach to intracerebral hemorrhage.
Yeah, I think it's probably, I mean, the excitement about a new approach brings two important things to plan in the future. Next trial, so keep in mind the scientific uncertainties about that, but also being ready to organize our pathway care to have this option. And even though we had a huge trial that would be positive, I don't think that worldwide we would be ready to implement such an approach. And I keep seeing ICH as a medical emergency, and we as neurologists have to organize things, or stroke specialists have to organize things so that there might be in the future a surgical approach. We are not there yet, but we have to be ready in terms of the way we see things and we interact with neuroscience people.
And that is a good keyword, I would say.
Well, and I think it also really nicely connects, I think, the findings of the second trial, which also ended with that statement, I think, that ICH is a medical urgency. Yeah. And so then also maybe talking a little bit about that trial, which did not include a couple of hundreds, but thousands of patients worldwide. So what were your initial thoughts, Preston, then, when that was shown?
So I was extremely enthusiastic because the burden, the majority of the burden of intracerebral hemorrhage is borne by low middle income countries, and that's where Interact 3 happened. Second, it was enormous, and we want big hemorrhage trials. We've had very few of them in the past. And third, it used an intriguing design of an intervention that we want to use in everyday practice, organised care for our patients with intracerebral hemorrhage, and we want all the participants in a trial to use it. So the way to do that is a step wedge trial where sites are gradually randomised in blocks to introduce the intervention. So everybody got the intervention, really patient-centred approach. And then finally, it addressed the problem with these bundles of care where we can't do them individually randomised and give Charlotte one type of care and Silke another. We have to randomise hospitals. But those trials are big and dirty. So despite all of that, they've got a remarkably consistent result on a very important outcome. And Interact 3 was the trial that increased my heart rate today.
Yeah, I think it's of great practical relevance, because I think it will change the way how ICH will be treated from now on, I guess, because nobody can just disregard the results, which is basically telling us, don't ignore ICH patients, keep the pressure low, keep the temperature in normal ranges and the glucose in normal ranges, not talking about reversal. And I think that has a major impact on daily practice.
But I think that also emphasizes again the importance of stroke units.
Yeah.
And I think that was also mentioned at the end of this presentation. Don't leave them in the emergency room. Take them to the specialized wards. Yeah.
And I think you can see the practical impact by when you looked at the curves. You didn't see so much difference in between the groups when you look at glucose and when you look at temperature.
Yeah, just blood pressure.
Yeah.
The only thing is the blood pressure, and my belief is that it's a blood pressure trial, but all what went wrong in those trials we had before meaning controlling all the other confounders, that went right here. And this is probably one of the reasons why we see this result.
Well, I want to thank all the three of you for your insights so quickly after being presented the results. And so for the next 50 minutes, we'll be talking about the opening of today's plenary session, which was about sustainability. But thanks very much.
Thank you very much. Thank you. Hello everybody, we are here to talk about a very important and very interesting topic. It was the first speaker of our plenary session today. It's sustainability in stroke. We have heard that human beings, human activities actually feed into climate change, and then climate change, vice versa, causes more diseases which needs more treatments, and that starts a vicious circle. We're here with a panel of experts, Christian Schulz, from the Klug Institute, the German Alliance for Climate Change and Health, and he leads a group which investigates how climate change and what medicine can do to improve treatment without affecting the climate too much. Stephanie Debet from the University of Bordeaux, who looks into how young patients with stroke and climate change are influenced, and Rustam Al-Shahi Salman from the University of Edinburgh. You are the champion of sustainability at your university. So congratulations to that. And my first question is, Am I still allowed to use papers to take my notes?
If you recycle it, Silke.
Oh,
it's
right, okay, wonderful. Oh, wonderful, wonderful. So would you mind telling us a bit more about what does climate change do with health, and what can we do to stop this vicious circle?
Well, I think climate change is quite narrow. It's connected to many other Earth systems that are of decreasing quality, and that's why we have health effects in all organ systems, including mental health. So we have to amplify our perspective to come to the right conclusions.
All right, and what can we do? Is there any idea?
Yeah, you talked about like small steps,
Yeah.
and so if people watching now are thinking, we go back to our hospitals, so what are kind of small steps that you would recommend?
I think small steps are not sufficient. I didn't talk about small steps.
No, but I said everyone has to make a difference. That's what I mean, basically.
Yeah, that's a point. But we have to change our perspective away from our personal footprint, including, for example, the perspective within a hospital, within an institution, towards our handprint. So we have influence that depends on our personal position, including the institutions, for example, and then we have to build new alliances and look for allies in that context that help us to change the conditions.
Yeah. And does this imply? Sorry, but does this imply going to the government as groups, or do you also have suggestions for things that we can implement in the hospital, like just on a department? Which kind of strategies could you implement within a department? Say anesthesiology is your department, first neurologists. Which kind of?
For example, in anesthesiology, we have very simple tasks we can do to reduce climate impact. For example, we can avoid anesthesia gases. In general, it's complex. We have scope 1, scope 2, scope 3, the greenhouse gas protocol, and therefore from there, different fields of action we must address. The NHS is in a leading role worldwide because they have a transformation path up until net zero emissions. But of course, it always includes building alliances, and that includes to speak up towards policymakers, towards society, because for changes at the end we need majorities.
Maybe, Rustam, can you tell us what you've done in your department to address this, to make it a bit more sustainable, what we do? I mean, we definitely have to go on monitoring patients on the stroke ward. I think we can't switch off all these monitors. We certainly have to treat patients with asthma, COPD. We might change to more modern inhalers. But what else can we do?
Yeah, so I think there are all sorts of dimensions. The first thing is we have to live and breathe sustainability ourselves and lead by example. So I cycle to the hospital and back home every single day, regardless of what the weather is. And we need to signal that to our colleagues and our patients. We know that non-communicable diseases have all the lifestyle risk factors associated with environmentally unfriendly behaviours underlying them. So we can improve our patients' health by implementing low carbon approaches to life. But then how do we actually deliver healthcare that is more sustainable? How do we reduce waste? And there are all sorts of things we can do to look at scope 1 emissions, like how lighting is delivered in our stroke unit. Do we have lights that are motion sensitive, for example? Are we throwing single-use plastic cups away the whole time when we give patients their medication, or using something recyclable? But the most important thing for me in our care is, what are we already doing that is actually not beneficial and we could do without? And that's the uncomfortable truth about a lot of what we do in medicine.
What about these teleconsultations, which more or less started due to the pandemic, and there are now multiple publications saying that actually this is quite climate friendly? Don't ask all patients into hospital. Do you think this could be something we should think about, or would we lose quality? Is that possible?
Stephanie, what do you think about that?
I'm not so sure, but I'm asking the expert whether it is so climate friendly, because it is entailing also a lot of server use, and so I don't know. And I think we should definitely not relinquish or abandon very essential aspects, which are the contact with patients. And I do think if there is a convenience for the patient also to have remote consultations, and we have seen that there are some situations where this is the case that can be done, but I think essential things need to be kept. But I'd like to come back also to one comment that you made, which I found very important, that we have also a responsibility as physicians and experts to report on the impact of climate change and environmental changes on health to the policymakers, because this may have an impact and maybe, sponsor change, or at least promote more rapid action. And perhaps we need to do more research on the impact of climate change and environmental transitions on, in particular, vascular brain health, because I think there is not that much data available on that. And certainly, we need more research to be able to report more groundbreaking results that will have a broader impact. What do you think? This is something that we have a responsibility for?
No.
Okay, I misunderstood.
don't think so.
Maybe.
No, not at all. But I think the evidence for what is going on is amazing. We have a huge evidence of what will happen. We have evidence about climate tipping points of the Earth systems. We know the relationship to the burden of disease, and we have a more or less a little understanding of how these interact and how these could lead to a disaster, including, especially in the healthcare system, being the first line of defense in this context. So I think we have enough evidence, but it's a normal reflex, as I said in the talk. The surgeons want to reduce waste, and the researchers want to do research. That's logical, because it's what they know, what they are able, what's their business. But apart from that, we have to strategically look for the biggest levers, and these are the social tipping elements, and then we have to analyze our environment, our networks, and look for the multipliers.
So you're talking about research, and Rustem, you are doing a lot of clinical trials, and so you also mentioned that during the talk that during research is not always so sustainable. That also comes with sort of an element of waste sometimes, and so how do we need to think about the design of clinical trials and sustainability?
So the first way to reduce the carbon footprint of clinical trials is to not do clinical trials that do not need to be done. Let's only do big, large, practice-changing trials that are methodologically sound. We saw during the COVID pandemic two things: a fantastic response to the problem and the use of virtual methods in trials, lower carbon methods of recruitment, consent, follow-up, that can reduce our carbon footprint in future. But we also saw an infodemic, a lot of very small trials that were unnecessary and not well conducted. So we need to reduce what we do and do what we do well with a small carbon footprint. And finally, if we really want to make maximum impact, the interventions we should be researching are ways of delivering healthcare more sustainably.
Which discipline would you think is the leading discipline in medicine regarding the carbon footprint? Is there anything?
Hard to say. I think it's not the anesthesia.
Not the surgeons we heard?
No. It's diversified across disciplines, across countries. It depends on networks. It depends on personal relationships, for example, and this is how this evolutionates in the different regions and context.
So we always talk about sustainability regarding climate change, but sustainability sometimes a little broader than that. And I think about the statement of the United Nations. Stephanie, what do you think about that?
Yes, I think it's really important to consider sustainability as part of the United Nations Sustainable Development Goals, the 17 Sustainable Development Goals that I'm proud to wear, because I think if we want to make a difference, of course, climate action is essential, but we have to think of other sustainability goals, which include equity, which is very important, a major question for stroke, which maybe can be achieved by partnering in a more global fashion, and also engaging into educational activity that have a more global scope. And we were delighted to have several invited speakers who were also teaching us about stroke care and stroke research, high-level stroke research in Africa, where sustainability has another meaning, another dimension. We were just discussing with Dr. Schulz how urban health plays a major role in health in general in many places, but increasingly also in the global south and developing countries. And I think we have to think globally. It was wonderful to hear also the impact we can have through the session with WHO and thinking of our global European scale impact, but also on the broader international scale. I think sustainability is a very broad term, and I think we can contribute by improving equity in stroke care, stroke prevention, stroke research more globally.
Yeah, absolutely agree. But on the other hand, we all have, as you said, we have to start with ourselves in our departments on a very small basis, because then that was your last slide. One person pushes
triggers the next one.
Yeah, exactly. Otherwise, we will not.
I think that the narratives about sustainability are not very strong. All these sustainable development goals, they are all interconnected. So if we address one, we address all the others because they are connected. Yes. So what I think is much more helpful is to talk about resilience. We need to talk about the resilience of healthcare systems in the next 10, 20 or 30 years. And then we are able to draw the right conclusions for that, what we have to do in the next couple of months or years.
Yeah. I think there's one more point. Stephanie, go ahead.
The 17th Sustainable Development Goal is a partnership for the goals, and I'm coming back to your comment that maybe, and also your comment, maybe we should do less trials, or maybe some that are not necessary can be replaced by global coalitions that to try to partner and improve the situation through interdisciplinary collaborations and partnerships.
Yeah. But I found it's still quite an abstract topic. So if we now to our audience, what would we recommend as what can they do when they go back to hospital next week?
This is the same question. It's the same question every time we talk about this.
Yeah,
what is concrete measure they do when they go home? That's difficult because, as I said, the perspectives are different, the disciplines are different, the professions are different. The power everyone has differs between one from the other. And that's why it's important always to see the bigger picture and to put in the big context. At the beginning, this is not concrete, but if you have this in mind, it's more easier to come to concrete
solutions and actions. Yes,
and such as and collaborate, right? If they go back home and start collaborating in the hospital to work on that goal.
That's very important because if you work alone on this topic, it's very hard for your own mental health, and that's why you need friends and allies to stay in your own comfort.
And to start the discussion also.
Yes, definitely.
Then,
I think that's a great message for all people watching, and to take that message home. And I hope that you will enjoy the rest of the day at the conference today, but also tomorrow.
Good afternoon. My name is Joanna Wardlaw and this is Esoc TV. Thank you for joining us. This afternoon we're talking about diversity and inclusion in stroke research, but first I'd like to introduce our panel. My co-chair, Daniel Sturbian, who's currently treasurer of Esoc and a neurologist from Helsinki. Cheryl Carsell, who's an NHMRC emerging leader from the George Institute at Sydney, Australia. Valeria Casso, who's former president of Esoc and currently treasurer at the World Stroke Organization and from Italy. And finally, Professor Mike Sharma, who's director of the stroke program at McMaster University, Hamilton Health Sciences in Ontario, Canada. So a very wide-ranging and eclectic panel.
Thank you. Very warm welcome. And now we are going to discuss about the diversity in the clinical trials. So we know that different people can experience the same disease actually very differently. And that is why it's very crucial that we involve people with different backgrounds, different life conditions, educational status, living experiences, age, ethnicity, race, sex, and even sexual orientation, so that basically every single community member can benefit from the science. And now I would like to over to Joanna.
Thank you. So Cheryl, this is something that's been a major interest of yours for some considerable time. I wondered if you could share some of your thoughts and perhaps more recent findings on this subject.
Thanks, Joanna, and thank you for having me here. So my work is mostly focused on gender, and a few years ago we published a study looking at randomized controlled trials in stroke that are published and registered in clinicaltrials.gov. And so we found sort of 270 eligible trials, and we looked at whether women and men, what their representation was. And so this was from 1990 to 2018. And throughout that year, it's been consistent that women are underrepresented. It's 40% of the population. There was a slight increase in 2006, going up to 44%, but basically it's 40%. And so we wanted to look at it a bit deeper now, looking at it by the disease of the population. So we wanted to sort of quantify the sex disparities in clinical trials. And so what we did was we calculated the participation to prevalence ratio, which was defined as participation of women in clinical trials versus the prevalence of the disease in the population. And we found that women were underrepresented compared to their prevalence of the disease throughout, but this was most common in trials of intracerebral hemorrhage, as also we saw today, in trials that enrolled with a mean age less than 70, so younger participants, in trials that had non-acute interventions and rehab trials. And I think just our area wasn't really looking at race and ethnicity, but this is also likely the same underrepresentation for ethnic minorities.
So from what you've just said, it actually sounds like that's most trials.
Yes, so a majority of the trials underrepresented women, yeah.
Okay, and were there any things that particularly shocked you in that?
Unfortunately, no. So I was expecting that there would be underrepresentation, but maybe you're right. I think one of the trials that popped out was that these secondary prevention trials were actually enrolled less women, and you would think that in secondary prevention trials, coordinators are not as rushed to probably explain things, and women would have more time, but this doesn't seem to be the case. So there must be something there that's going on that we need to explore.
Okay, I mean, did you have any thoughts? I mean, you mentioned about younger people and the secondary prevention, and also I think the more severe acute. Did that suggest anything about the participant potential willingness to participate, or any things like that?
Yeah, that is a really great question, Joanna, and I wished we had data, particularly in stroke participants, but we don't. There's a lot of data in cardiovascular disease trials looking at secondary prevention, more people are more likely to go into it, and less intervention, so non-interventional trials, more women are more likely to be enrolled.
Okay, and you mentioned that there was a slight shift in the sort of mid-2000s, I think.
Yeah, I cannot explain that.
Okay.
Yeah, that is difficult. Might need to be looking at a bit more.
Okay.
Thank you, Cheryl. Now, I may have a question where we can start from Mike. So, what do you think that actually at the moment are the biggest concerns or barriers that are preventing the diversity in the clinical trials?
So it's a great question, and I think there are multiple barriers. So Cheryl has spoken eloquently about her work regarding sex and gender, and I think that still needs to be tackled. In prevention trials, where I do most of my work, I think that the time frame actually works against us, because in an acute trial, you have to get every patient you possibly can. Here, all of your internal barriers come up, all of the issues that you think about, biases come into play. So one of the things, that we've been looking at is how to increase diversity in terms of race and ethnicity, which are not biologically defined, but self-defined. One of the things we managed to do in some of our trials, like Oceanic, that Cheryl is collaborating in, is to increase the geographic scope. So we get a more diverse population by going to countries where people are. Even with that, there are areas which are completely unrepresented. South Asia, for instance, large population with very poor representation traditionally, and sub-Saharan Africa. And one of the things we have to remember is that even though these aren't biologically defined states, the health behaviors, interactions with the health system, all of these things which influence outcomes may well be different. May be different for populations in their native countries as opposed to immigrant populations. And I think ultimately, Daniel, what we have to look at are the internal barriers. So I find few people today in our business who say, no, we should not do this. More often what I find are people who are willing but hapless. We just don't know how to go about it. We don't understand why it happens and what we can do about it.
Thank you.
Can I ask, I think we'd all like to try and go to as many countries as possible and to as broad a community within our own countries as possible, but you're always struggling with funders and what they're prepared to fund, and budgets are tight and so on. How do you persuade funders that this is a really important aspect of the work and not something which could just be pushed aside?
So, one of the advantages we have in Canada is everyone in Canada, apart from a small proportion of the population, is from somewhere else in a very short span of time. So when we talk to our funders, what we say is really, we're talking about the Canadian population, right? That is, we're Italian and German and Finnish and Australian and all sorts of things. So that is really part of it. The other thing we've done at the Institute, at PHRI, is we've pieced together public funding from multiple sources. So we go everywhere we can. There's one of our epidemiologic studies which has 40 different funding sources to go for it. Now this is hard.
There's a serious administrative burden on that.
It is, but you do what you have to do to get it done. One of the things we'd like to see is more collaboration between national funding agencies, right? So that we could pool our money specifically for this purpose.
So I can echo your comment. I went to primary school in Toronto and my class was a total microcosm of the international community. So I get where you're coming from.
Actually, Mike, you touched quite important question about the problems of the secondary prevention trial, but sometimes in the acute or hyperacute trial, imagine now we have been talking about the diversity, and let's talk about the clinical diversity. Let's talk about the stroke patient with dominant and non-dominant strokes. And of course, if the patient has a dominant stroke, he or she cannot actually, maybe not understand or sign the contract, the consent. So what do you think?
There's no question. One of the barriers that we didn't understand until recently that prevented women from getting AIDS is when we set an age cap. So very common in trials to say no one over the age of 80, but women have strokes at a later age. They're less likely to have a spouse or a partner still alive to give consent, and I think that was one of the drivers.
Maybe I would have still one question for Valeria, because Valeria was, as president of Esoc, quite active as well on the European Union level, and there was actually at the end of the January, I think in most of the country was accepted a directive that deferred consent can be used in the trials. So, and you, Valeria, most probably know that in different countries, despite that we are all in European Union, we have actually different policies. So, would you like to comment maybe on?
That's a big issue because there's a direction from the European Union, and I think this people sit together, discuss the issue, and they implement. Like always, the implementation is not working, and this is for me unacceptable because now we should have. This is, I think, the view for Europe. If one country accepts it, then the rest of the country should accept it. We are one continent, not completely homogeneous, but we are almost there. So I think we have all our laws or GDPR, and we are very bureaucratic. So if we have one application, why shouldn't use it for the others? So this is especially research, and what I see, doing research in Europe is becoming a nightmare. So it's really a nightmare. And think about us, because we are stressed that we come to the day that we have finally our trial. Then we have to transmit to our patient, trust us, okay? Because what you said about diversity is mistrust. I never thought about this because I came with my blue eyes, which I do not have. You say this in German. Okay, now I have a trial. I want to include you. People don't trust you, especially if you have a different color. If I'm white, I speak to a patient with a black collar, they don't trust me. They think that I'm trying to give them something to use them. And this mistrust barrier is one of for me, the most important barrier I have to overcome. I learned this from women because women don't trust us. Even if we are women, we try to say, well, listen, to be a female patient is difficult, to treat a female patient is difficult. So then I learned we have to use a special language. But then I want to go further, to diversity. And I found the same pattern, this deep mistrust. Maybe in Canada, where you are more a melting pot, you don't face it. But in Europe, still I see this very high mistrust.
Thank you.
So, before we go on to talk about the potential role of regulatory authorities and funders and publishers in this, while you were talking, and also Cheryl, one of the things that's often struck me is that, we come to a conference in Europe and we represent many different healthcare systems, and some of them are fee for service, some of them are socialized healthcare systems. Do you have any evidence that participation varies according to the underlying structure of the healthcare system, and that perhaps, in a country where it's either insurance-based or it's fee for service at the point of care, people are put off being in research because they think, oh, this is going to be an extra bill or something like that? Or do you think, on the other hand, that becomes a form of potential coercion to get people to participate when in fact, perhaps they wouldn't? I don't know what your thoughts are. I don't know if there's anything in the literature about that, your experiences.
So, if I can start.
Yes.
The best example we have is Canada and the US, and the Canadian healthcare system is unique in that we have no private payer system, so you cannot do it. It is against the law. And we compare it to the US. We have much higher rates of participation because our patients do not feel that we're there to take advantage of them in any way. It's not to our financial benefit or anything of that nature. The US historically, even internationally compared to Europe, very low rates of participation. And Valeria used the word trust. Talking to my American colleagues, this is a real barrier. So when they approach an appropriate patient, their rate of getting consent is much lower than ours because of this mistrust that's there. With some minority groups, as you mentioned, there's historical mistrust. So Indigenous population in Canada has not been well dealt with historically, and that mistrust is built up. Some of the immigrant populations, depending on their country of origin, do not trust authority, do not trust systems, and so that I think explains part of the gap.
And do you still have pockets where the language of origin is the dominant language, and that for some members of that community it may mean that there is more difficulty interacting with the healthcare system? And we certainly experienced that in the UK, where there are large communities of people from various different parts of the world where they may not have integrated quite so well, and at least some members of the family, for various reasons, do not interact with healthcare or other outside influences, and therefore even after quite a number of years, they can maybe not be English speakers, and that invokes translation issues and things like that.
So we absolutely do encounter that, and it's more common in older patients and more common in older women because
they do not work.
Exactly, so they don't have that requirement.
Okay, so my next question would be for Valeria. So what do you think about how the diversity, or actually the lack of diversity in the leadership of the clinical trials, would affect the conduct and the outcome and actually the design of the trial?
This is a very good point, and again with Oceanic we were very attentive to this. We tried to involve different leaders from different countries that people can recognize themselves.
Can you just explain what Oceanic was, just for anyone who's
sorry.
not everybody, just generally, briefly?
Yeah, asundexian is the factor 11 inhibitor, and it's used in acute stroke, or I'm more involved in the atrial fibrillation trial as let's say prevention treatment for stroke prevention treatment in AF. So what we did when we first designing the steering committee and involving our colleagues, we asked them, we really looked at gender and diversity, because when you look at the face of the one who is talking to you and you recognize yourself, then you feel safe. And you and also to say, we thought about this. Maybe we will not succeed, but we put it. It's one of our, let's say, main aims where we want to reach. And this, I cannot promise you that it will be like we want it to be, but at least it's a step forward in the right direction.
So from the point of view of regulatory authorities, and we've touched on funders a little bit already, but also publishers, do you think they're doing as much as they could? Do you think there's more that they could be encouraged to do? I mean, you know, with regulatory authorities, like you say, we just seem to get a higher and higher burden of administrative aspects to do with, you know, clinical trials in Europe. Much of it is obviously very reasonable, but sometimes you sort of feel it's gone a bit too far, and it's bluntly applied across every situation, when in fact, you know, that particular rule may not apply in that situation. I mean, are there efforts to try and encourage overt evidence of gender, you know, addressing gender or ethnic or other disparities in applying for funding, and then also in the regulatory authorities that, you know, you're aware of in any of your jurisdictions?
For example, for the Horizon 2020, there needs to be a work package on gender. For example, we're doing the Prestige AF, we have this work package on gender, on adhesion, what are the barriers to physician or for patients to enter the trial. So there's from the part of the European Union, yes, a lot of attention. Again, we do not know how much it will influence, because we know how many of this Horizon 2020 project finished with the right number in the right time. But still, there is something trying to do in the right direction. Publisher, I think the publisher should say only 30% women. It's not acceptable. At least you explain me why. At least you say there are no black population, there are no Hispanic population. Explain me why. No enough in Asian. Explain me why.
I mean, there would be situations in which male-female disparity would not be unexpected, because that reflects the prevalence of the disease in the population.
Yes, Cheryl.
However, one has to be careful, and that doesn't become an excuse.
I agree with what Valeria is saying, that it needs to be sort of like a concerted effort with different stakeholders. So you have the funders requiring you to analyze this or to collect this data, but also you have the journals who are requiring you to report them. So it needs to be kind of multi-pronged approach, and Mike would have a lot to say about funders and their success in Canada.
You know, CIHR, our national granting agency, requires all investigators to take a training module in sex and gender, and part of the grant has to explain how you are going to handle it. So what steps you've taken in recruitment and analysis, and why this applies. The FDA now requires that in all of the industry-sponsored trials that this be adhered to and reported. There's a scientific reason for it. You really want the effect size to be correct, so to reflect the population you're treating. The state of Hawaii sued BMS over data in Capri because they did not include enough of an Asian population, which have a high prevalence of the loss of function allele. So that clopidogrel is not converted. This was over 10 years ago, right? So the state was funding this drug when a large proportion of this population would not have an effect, so it was overstated. So this has gone to the regulators. New England Journal now requires a table of how representative your population is with respect to the disease. So that needs to be published. I think all of these steps at every level are going to be important just to remind us of it and have us take steps to change it.
Maybe my next question would be for Cheryl. So I know that there is not a clear answer, but I still need to ask. So you think that mostly in the clinical trials we have the inclusion criteria that there cannot be included a woman of a childbearing potential. Sometimes you have age limit, sometimes you have this statement, sometimes there is you need to do a test, which of course takes a minute. Of course there's difference between acute and hyperacute. But you know the definition actually sometimes for the investigators are very complicated. So how would you comment?
I think you're right. When you're looking at barriers, there are certain trial-specific barriers. And before, Mike mentioned that there was this age barrier, that a lot of trials had, cut off age less than 80 or more than 80, you can't enroll people. But I think lately there hasn't been any age requirements in most of the trials. So I think we're successful there.
At least there.
Yeah, exactly. But in terms of women of childbearing age or women who do not take contraceptives, it's a bit more complicated, I think. There is really a lot of push of women who are even pregnant or in childbearing age to be eligible for trials so they can access those treatments later on, because if we have data for these women, then doctors would be more likely to prescribe them. But I think it's a very complicated issue and should be left up to the participant. You need to probably explain all these risks and benefits and let them decide.
Thank you.
Yeah, especially about pregnant women to exclude. This is, I think, the next frontier, because it's not possible that a woman with a stroke comes who's pregnant. You don't say she has a stroke. You say she's pregnant. No, please. First of all, she has a stroke. You have to save her life. So, and then we think about the fact that she's pregnant, and this is for me the most important point. But we don't have so much data, and we need the data, and it's unfair. Now it's unfair to exclude pregnant women from the trial. It will be a hard job. It will be very hard. I know it's easy to talk, but then we have regulators and everything. But I remember when I had my son, more 30 years ago, to get only an antibiotic, it was like, oh God, you cannot take anything. Luckily, something has changed, but this was a nightmare. Nothing, even for headache or for everything. It was, why not?
So, just thinking about what more we can do as individuals. I mean, I'm just thinking about the situation in the UK where some of our major funders, because for years there were issues in preclinical research where it was traditional to use all male animals, etc. And then, of course, the results don't apply. And the Medical Research Council and other major funders took quite a strong stance on this and other aspects of preclinical research as well, and now have very predefined information which applicants need to provide, and this is monitored, and people have to go on training courses and so on and so forth. I'm not sure that it's got quite the extent that for a clinical study that is also emphasised. And the other thing is that there's a degree of proportionality. So for a very early phase trial, it might be perfectly reasonable to have a very restricted population, but you kind of rapidly extend out to where you've got a large phase 3 clinical trial, and that's where a lot of what we're talking about really applies to, because it becomes really important to know that your intervention will apply broadly and you're not just extrapolating and making assumptions. So I guess the question is, I mean, there's obviously a lot happening already, but what more can we as individuals or as members of an organisation like ESO do to try and encourage our colleagues, because it's got to start at grassroots as much as anything, to make sure we think about these things when designing trials, but what can we also do to perhaps put pressure on, well, regulatory authorities or other, groups that might have some influence in this to try and bring it up the agenda a bit more?
Look, I
Or
think
maybe it's us that are the problem, not the funders and everything. Maybe they're way ahead.
But we need to make this a standard part of clinical trials and design. So, Oceanic, which Valeria mentioned, in the Oceanic stroke trial, we've established a diversity and inclusion committee, and we're privileged to have Cheryl as a member of that, to advise us on how to do it. So what we've done before is we've amateurishly gone about it. We've thought we're doing the right things, but clearly we're not succeeding. So we need a thoughtful, well-designed approach. Our hope is once that trial is done, we'll leave a toolkit, a roadmap behind for trials that follow. And really, Cheryl was saying earlier, it'd be nice to see that committee as part of every trial, like you have a DSMB.
And is there anything showing up already that perhaps was a surprise, or that was suggested that maybe you weren't doing already, or that you think, oh, that's a good idea, why didn't we think of that? Anything at all so far, or still work in progress?
Maybe I'll let you go, Mike.
Well, so we've just started, and so I can't say that. What I will tell you is, in the early going, the proportion of women is dismayingly exactly where it has been.
I have actually my last question would be that in the beginning I thought that there has to be a large diversity. I mentioned like living conditions, life experience, which in a broad term means as well people with drug abuse, for example. Now, in each and single clinical trial in the exclusion criteria, we have a clause that says that if it's foreseeable that this patient will not be able to come to follow visit, so we shall not include him. And this is a potential problem. So maybe each of you can comment briefly.
I can tell you, Mike, I had to exclude a patient. He is originally from Nigeria with amphetamine use. So to our trial, due to the strict exclusion criteria. So he is quite compliant. He would come back, but due to the fact that he had drug abuse. So it's an issue, and if you, especially when you live in low social, let's say, condition, it's difficult to come back to the doctor. It's difficult.
It's a hugely important population. The practical issue is this: is every time you lose a participant, it hurts the study power significantly.
That's the point.
And funds are limited. So the way we phrase it, by the way, is we don't say if you have addiction issues. What we say is if the investigator doesn't feel that this participant could complete the requirements of the trial, they may be excluded. And so it gives you some latitude. But I think ultimately results of trials like that, we have to be careful to say we're not sure if we can generalize it to people.
Thank you.
Okay. Well, thank you very much. We've got a couple of minutes left. What are you looking forward to tomorrow?
Me personally, maybe for the last session of the large clinical trials.
Absolutely.
Yeah. Well, we've had two really interesting sessions so far. Lots
today,
of surprises and interesting things, and we had a very interesting epidemiology session this morning, which included matters to do with gender and equality and so on. So I think I kind of feel that there's nothing that's going to suddenly radically change everything overnight. It's a matter of sort of pushing at the envelope and just keep pushing, and then you may get sort of jumps and hops, and suddenly the door will open and it'll become much easier. But I suspect it's more a matter of just we're dealing with society and it's complex. So but I guess is there any kind of network that exists? I mean, within your trial, obviously, but anything more broadly that might people are interested in this, or they want to look for information that might help them putting together their next trial? Is there anything you could particularly advise that they should look at, or
your model
helpful tips?
Do you know, we should do this. So
that's a good idea.
What we should leave behind is a repository of tools, maps, and things.
That would be fantastic.
We are planning a couple of publications, but it'd be nice to link it to these things.
Okay, well, it's been fantastic hearing about all of that, and may the field continue to move forward in a productive and more inclusive way. So thank you very much all for your participation.
Yeah. Thank you.
Thank you for having us.
Welcome to the PI interview. My name is Karin Klein and I am here with Professor Craig Anderson, Dr. Lily Song, both from the George Institute, and Professor Yu from the Department of Neurosurgery of the Sichuan University in Chengdu. And we are here to discuss the results of the intensive care bundle with blood pressure reduction in acute cerebral hemorrhage trial, INTERACT 3. Dr. Song, can you tell us what was the rationale about your trial?
We all know the hematoma, intracerebral hematoma is the most serious but least treatable form of stroke. Before this study, no medical or surgery treatment had been proven to get level 1 evidence from the larger clinical trial. And even for the most promising treatment, blood pressure lowering, the evidence was controversial and the guideline recommendation is modest. So it might be because the treatment effect is not big enough, and so only a single treatment cannot improve the functional outcome. We therefore think maybe we can combine the management together, and maybe the combination of medical treatment can improve outcome. Yeah. And we also did some secondary analysis from INTERACT 2 trial, and we found a higher score assigned to baseline blood pressure, glucose, temperature, and prior to use of anticoagulation could independently predict the poor outcome. Yeah. So according to the above rationale, we designed INTERACT 3.
Yeah, thanks so much. Professor Anderson, so the intervention was a goal-directed care bundle. Can you explain us what exactly a care bundle is?
So a care bundle is a package of active management with particular goals. And so we had parameters around initiating the treatment as early as possible and achieving particular target parameters within a 1 hour period. And we worked with the various systems of care within hospitals to ensure that these parameters could be achieved. And most of this is around active nursing care and a more interactive engagement with the patients. So it's a package of care to streamline the management in all types of patients with acute intracerebral hemorrhage, as opposed to just applying blood pressure lowering or some other treatment in a selected manner. Now, there's a great temptation to want to try and unpack that care bundle and decide, well, was it this or was it that? But I think we've got to remember that we evaluated the whole system, the whole use of that care bundle. And so then there's the potential for the interaction, as Dr. Song has mentioned, a better treatment effect by combining these together, but also just applying a much more active process of management within the hospital system that made a big difference.
Yeah, I see. And before I go to Professor Yu, can you just repeat one more time what was the main result of the trial?
So when we implement the care bundle as part of a routine package in the hospital system for all patients presenting with intracerebral hemorrhage, there was a 14% relative improvement in their chances of having a poor outcome. That's that's dying or having severe disability. And we put that into a metric, which you may have heard of, number needed to treat, and our number needed to treat with 35, which is a very strong treatment effect for this package of care.
Yeah, which is an important achievement for all patients with ICH and also I think all over the world. And that gets me to you, Professor Yu. How do you think that the results of INTERACT 3 will impact on the neurosurgical clinical practice in China?
Okay, thank you. I think have a great of impact to China, because from this morning we published this paper. There are a lot of Chinese neurosurgeon and neurologists know this article, and they have a lot of discussion in China right now. So this, in fact, in China, it's beyond what I expected. But in future, I think there are some changes in China. The international will bring to China. The first is some change of concept for the treatment of intracerebral hemorrhage. The concept, I think, the main change is from single factor, care of single factor, to care of bundle. Care many factors, especially include our research, temperature, diabetes, blood pressure, etc. Many factors. This massive change of concept. The second is, I think, maybe change in China some guideline for diagnosis treatment of ICH. The last change, I think, I'm a neurosurgeon. Most of the time, I pay more attention to the surgery. In our signal analysis, there is a good functional outcome for surgery. So I think in the future, maybe I do more surgery, because the surgery for deep brain hematoma is controversy in the world in 10 or 20 years. In China, most of the time we do surgery for the big hematoma in deep brain, but no evidence for this surgery. In this secondary analysis, we get some evidence so that we can do the surgery briefly and it's legally, rationally. So I think in the future in China maybe do more surgery. I also hope the surgery treatment for the ICH patient can benefit for all the patient.
Well, Professor Yu, I wish I could talk with you longer about these important results, but I think we have to refer to the Lancet paper that is out, and we can read all the more details. And I'd like to end with thanking you for the great effort of including so many patients with ICH and making a difference for many patients around the world, I think, with the completion of this trial. Thank you so much.
Okay, thank you.
Thank you.
Welcome back to the PR interview for Esoc 2023. My name is Lingxin Li. I am the chair of the PR committee for the conference. It's my great pleasure to welcome Professor Bart van 't Wulf from the Netherlands, who is the PI of the Precious trial that we're going to discuss next. So Precious was presented yesterday in a plenary session which looked at prevention of complications to improve outcome in elderly patients with acute stroke. So Bart is going to be interviewed by Professor Christine Roth, who is Professor of Stroke Medicine at Kew University in the UK. So welcome Bart and Christine, and over to you.
Thank you. Well, congratulations on on finishing and completing a study which is so difficult during the pandemic, and getting patients recruited and getting comprehensive and results which we can act on. So just tell me, what was the idea of the trial and why did you choose the interventions you chose?
Thank you, Christine. We assessed whether a pharmacological strategy to reduce the risk of infections and fever improves outcome of elderly patients with moderate severe to severe stroke. And these pharmacological strategies were very simple and safe and inexpensive. And these consisted of paracetamol, metoclopramide, an antiemetic drug, and ceftriaxone, an antibiotic drug, which is frequently used in patients who have post-stroke pneumonia.
There are a number of antibiotics of choice. Why did you use ceftriaxone?
Across Europe, and at least in the Netherlands, where I come from, ceftriaxone is the preferred antibiotic for patients with post-stroke pneumonia.
Because in the UK, where we are, we're not allowed to use ceftriaxone because of high risk of C. difficile infections. So we were quite surprised, and I think some of the UK centres had problems with recruiting patients.
Yeah, and fortunately we proved that the risk of these Clostridium difficile infections is very low if you use ceftriaxone.
Why did you use paracetamol?
Because it's safe and inexpensive and widely available across the world. And because in a previous study, also performed in the Netherlands, it was shown that at least in patients who had the highest risk of developing a fever, this might improve outcomes.
Yeah. And the metoclopramide, why did you choose that?
Because of your MAPS trial, which showed that in patients with a nasogastric tube, the chance of having a pneumonia is much smaller if you use metoclopramide.
So what outcomes did you take for the study, the main outcomes?
Yeah, the main outcome was actually the score on the modified Rankin scale at 90 days. So the usual outcome in acute stroke trials.
So we want to know whether patients have a better outcome, whether they've got a better life afterwards.
Yes.
You also had an outcome of pneumonia. Did you?
That's correct.
Yeah.
We also had pneumonia was one of the secondary outcomes. And we assessed this both as diagnosed by the treating physician and as diagnosed by an expert panel.
Yeah, so you've got a safeguard on quality.
Yeah.
Just tell me what the main outcomes were of the study.
Unfortunately, none of the medications had any effect on functional outcome at 90 days, which came a little bit as a surprise to me because I'd of course hopes, but also expected that at least one of these medications would be of benefit. Now, remarkably, ceftriaxone nor metoclopramide had any effect on the risk of developing a pneumonia. Mm-hmm. So this was all quite disappointing, to be honest.
But I suppose it can also be a positive thing. We've all been worried about the antibiotics. So know we've got a real response. There have been so many trials on antibiotics. And I think at some point you want to know that really they work or they don't. And I think your trial has really told us that there's little point in using antibiotics.
At least preventive antibiotics.
Preventive antibiotics, yes. So I think that's really an important response. The other thing which I found interesting is that the infections were reduced and UTI was reduced, but there was no effect on pneumonia. How do you explain that?
Yeah, probably as has been suggested by others earlier, post-stroke pneumonia is maybe to a large extent a chemical process caused by aspiration early after a stroke, and that's maybe bacteria play only a little role in the development of a post-stroke pneumonia. So
you've been shown that the antibiotics do work because they've reduced the infection, but for pneumonia you need something else. And I suppose that brings us to the metoclopramide.
Yes.
You found that the metoclopramide neither reduced pneumonia nor did it do anything good for survival or quality of life. So tell me, any ideas why that might be the case?
No, actually, I have no idea because this was, now, as I told you, I had expected that this would at least have an effect on the risk of pneumonia. I personally think that this is caused in part by the fact that some patients have aspiration very early after stroke onset in the first few hours, and that we can maybe prevent aspiration at later points in time, but that the patients already have this aspiration before we start the trial treatment. And this is also something that has been shown by one of my PhD students, Jeroen de Jonge, who has shown that in patients with acute stroke, many have already have signs of pneumonia on a CT scan of the lungs in the first few hours after symptom onset.
Have you looked at that, at the timing within, because you recruited within 24 hours, have
Yes.
you got any data on that? That early treatment is any different than late?
Yeah, there was no difference whether treatment was started in the first 6 hours, in the first 12 hours or later.
One of the major differences between your study and the MAP study is obviously that you used the treatment for 4 days,
Yes.
whereas the original study treated for 3 weeks. Do you think that could have had an impact on the outcome?
I would certainly recommend to continue the study in the UK for, I think you use 2 weeks in this trial. So I would certainly not stop this this study based on the results of PRECIOUS because it's different. It's a different study with indeed a different duration of treatment, and we chose this shorter duration of treatment because according to the SMPC of metoclopramide, the preferred duration of treatment is 5 days. You've shown earlier that a longer treatment is safe, but we didn't want to have problems with the regulatory authorities about the duration of our treatment.
Yeah, but I suppose the risk of pneumonia does persist.
Yes.
So it may very well be that, and that's one thing we may find out in due course.
Absolutely, certainly in the patients with the more severe strokes.
Yeah. Do you think age made a difference? You obviously selected a group which is at very high risk of pneumonia, the older people. Younger people are less likely to get that. Do you think that could have had any other effects?
No, that's just speculation. One thing we found is that only very few of these older patients developed a fever. Only about 5% in the control group. And paracetamol did reduce the risk of fever to only 1%. But of course, this the proportion of patients with fever was so small that this is probably one of the reasons why paracetamol didn't have an impact on outcome.
Could there have been interactions between the treatments which had an effect on the effectiveness of one or the other?
Of course, we checked for interactions and we didn't find interactions between the treatments, or not relevant interactions.
Was the study powered to look at the interactions?
No. It was the groups were too small for. It was just powered to assess the effects of medication in each of the treatment stratums. So paracetamol versus no paracetamol, etc., and not the combination of treatments. These were just we considered these just hypothesis generating, but because the trial was stopped prematurely, the groups were just too small. So I think these analyses are actually of little use.
But I suppose it was stopped prematurely, but you've got so decisive results.
Yes.
That you've had your result, isn't
Yes.
it? You didn't actually need
I-
any more patients for answering the questions you wanted answering.
My personal idea is that I think that if the trial would have been much larger, we would also not have found an effect, but of course, you never know.
Yep,
Yes.
you wouldn't know that.
No, absolutely. Congratulations again on such
Thank
an
you.
important study, and thank you very much for watching, and I hope you have a nice evening.
Thank you.